So yeah, I'm Kaitlyn Lorenz with a mission for Michael. Myself and Inovo Detox Maryland Addiction Recovery Center are hosting this event for everyone. We are a primary mental health residential setting. We were founded in Orange County, California, where we specialize in super small milieus, 6 to 8 bed residentials that specialize in like mood disorder and mental health primary residential. So we get about 35 to 40 days of real good stabilization time so that this person may be ready to step down to an IOP or PHP level afterwards. We are newly in Vienna, Virginia on the East Coast. So we just opened an 8-bed residential there. And we're really excited to be serving the population on the East Coast because it's very limited in resources for mental health residentials. So yeah, if you have any questions about our actual residential treatment centers or our treatment centers in general, that can go in the chat and we'll hopefully be able to pick those questions out. That can be separate from the presentation. So now I'm going to introduce my co-host, Caroline Farrell with Inovo Detox and Maryland Addiction Recovery Centers.
Thanks, Kate. Hi, everyone. Thank you for joining us today. I'm Caroline Farrell. I'm the Community Outreach Specialist for Maryland Addiction Recovery Center and Inovo Detox in the Philadelphia area. Maryland Addiction Recovery Center is located in Towson, Maryland. We are a comprehensive, long-term extended care program for the treatment of substance use disorders and co-occurring disorders. A community reintegration model of care, Marc offers a long-term continuum where patients stay a minimum of 3 months and often up to a year. Patients begin in full programming, typically after a detox or a month-long residential stay, and eventually enter into either Marc's College Success Program or our vocational program. Throughout treatment, patients engage in our family recovery program, work on life skills development, healthy coping techniques, and personal recovery outside of treatment, which allows our patients to begin thriving while in treatment and supporting long-term and sustainable recovery. Inovo Detox is based outside of York, Pennsylvania, and we offer standalone detox, withdrawal management, and medical stabilization services for patients suffering from addiction and co-occurring disorders. Inovo Detox offers a first step for patients to stop active substance misuse, stabilize both physically and emotionally, and begin their process of treatment and their recovery journey. And I am super excited that Kaitlyn, Harkins, and Francesca from Serenity has agreed to present today. Francesca is the owner and operator of Serenity, and they've done some pretty incredible work over the past couple years, opening in the pandemic. They've been really able to service a lot of adolescents and young adults. And with that, I will turn it over to Francesca to introduce herself.
Hey everyone, thank you so much for joining us. I'm Francesca Santacroce. I am a licensed marriage and family therapist and certified advanced alcohol and drug counselor. So Serenity is located in Havertown, Pennsylvania, and we provide personalized mental health and substance use treatment for teens and young adults. We're an intensive outpatient program with a step down to outpatient and really specialize in dual diagnosis treatment. We offer a variety of services within our IOP and OP programs and really emphasize the importance of family involvement, peer support. We're also in network with a lot of the commercial insurers, as well as some of the PA CHIP programs. Today's presenter is Kaitlyn Harkins, who is one of the lead therapists at Serenity. She is a licensed professional counselor and earned her Master's of Education and Counseling from Penn State University. I've had the pleasure of knowing Kaitlyn and working with her for many, many years and was really excited when she joined the team at Serenity. She's worked extensively with adolescents, young adults, and families in a variety of settings, including her own private practice. She has a natural ability to connect with teens and young adults, and her knowledge and experience has really just been invaluable to us and to our clients. So I'm really excited that she has the opportunity to share some of that knowledge and expertise with you guys today. So with that, I'm going to go ahead and turn it over to her.
Okay. Thank you very much, Francesca and Caroline and Kaitlyn. All right, I guess I will get started with sharing my screen for today. There's my dog, Duke. He also says hello. All right, awesome. Can everyone see it okay? No. Yeah? Okay, great. All right. Oh, let me just... There we go. Okay, perfect. This is all good. Awesome. Okay. All right. Hello. Hi, everyone. Thank you so much for coming. I'm really excited and I'm grateful to be here and being able to present today. So today's topic is going to be on dual diagnosis trends. And we will be talking about the implications and treatment recommendations for teens and young adults. Okay, so to get started, let's just start with going over the learning objectives for today. So number one, identify 3 links between substance use and mental health disorders in adolescents and young adults. Number 2, identify 3 risk and protective factors of substance use disorder. And number 3, identify at least one component of adolescent and young adult treatment that increases positive outcomes. Okay. So, prevalence and treatment. Let's start with what is dual diagnosis. So, dual diagnosis is having both a mental health disorder and substance use disorder simultaneously. You may also hear me throughout the presentation address dual diagnosis as co-occurring disorder, as they are often used interchangeably. So let's look at some of the statistics. I know there's a lot going on this slide, but I'm going to break some of that down for you today. And then this slide will obviously be there for you for later, just to be able to, go back and look at. So according to the 2020 National Survey on Drug Use and Health, 73.8 million American adults had a substance use disorder or some kind of mental illness. 35.9 million had only a mental illness. 20.9 million were diagnosed with only a substance use disorder, and 17 million were diagnosed with a dual diagnosis. Of those 73.8 million, only 48% received some kind of treatment, and only 6% of the people with a dual diagnosis received treatment that addressed both substance use and mental health. If people with a dual diagnosis did receive treatment, it was most common for them to receive mental health treatment only, as you can see with the 42.3% statistic here. Research also shows the number of teens and young adults with dual diagnosis is rising, and that they're less likely to receive treatment for their substance use disorder than adults. It was also noted that the percentage of people aged 12 or older with alcohol use disorder was highest among young adults, around 18 to 25, which was about like 5.2 million people. Marijuana use was also highest among young adults. Adolescents who had a major depressive episode and young adults with any mental illness were found to be more likely to have used substances over the past year. So it's really important to assess for and also address substance use in mental health settings and vice versa. Okay, so the link between mental health and substance use. So the relationship between substance use disorders and mental health disorders is known to be bidirectional. So basically what that means is mental health can impact substance use disorders, and substance use disorders may impact mental health. The combined presence of substance use disorders and mental health disorders result in more profound functional impairment, worse treatment outcomes, higher morbidity and mortality, increased treatment costs, higher risk for homelessness, incarceration, and suicide than if people had only one of those disorders, but not both. Current treatment guidelines recommend that people with co-occurring disorders receive treatment for both disorders. Unfortunately, as we just saw on that last slide, many people don't receive treatment for either, and if they do, it's oftentimes not for both. There are many links between mental health and substance use disorders. 30 to 45% of adolescents and young adults with mental health disorders have a co-occurring substance use disorder. Some links that we have identified include self-medicating with substances, trauma increasing risk of substance abuse, coping with substances due to anxiety or depression, and low self-esteem. For example, the majority of the high schoolers that I see are coming in with something like anxiety, depression, and marijuana use, and we are able to help them recognize how they are all impacting one another. I also have noticed that a lot of teens come in believing that marijuana is not harmful for them and actually helps their anxiety, whereas in reality, studies show that teen marijuana use is linked to increased depression and suicidal ideation, and research also shows a decrease in IQ. Despite the negative outcomes, many teens do not receive substance use treatment. Even though there has been an overall decrease in stigma surrounding substance use, it still seems to be a barrier for seeking treatment. In my experience, parents often call in and they'll express concern about their teen or young adult participating in treatment with others who are also using substances due to a fear of negative influence. Clients and parents also report concern regarding what a substance use diagnosis may have on their child's future, therefore creating another barrier to treatment. We often provide psychoeducation to clients and the parents and highlight the benefits of receiving both mental health and substance use treatment, as well as the benefits of group therapy and peer support. Okay. It is important that we as providers, as well as parents, educate ourselves on mental health and substance use warning signs. So a few warning signs that we can look out for include, so I'll just go over some of the ones on the slide, poor performance in school, changes in peer group, sadness or hopelessness, irritability, anger or hostility, tearfulness or frequent crying, withdrawal from friends and family, loss of interest in favorite activities, lack of enthusiasm or motivation, thoughts about death or suicide or talking about it, changes in eating or sleeping patterns, restlessness and agitation, deteriorating relationships with family and friends, changes in appearance or hygiene, increased isolation, borrowing or taking money, missing prescription drugs or alcohol, and erratic behavior. So many of teens and young adults I've worked with report a lack of motivation and feelings of loneliness and hopelessness and not knowing how to express themselves or attempting to cope by isolating. So it's really important to look out for some of these warning signs and to remember that changes really can happen slowly over time and that the abnormal really can seem normal. It is also important to educate parents regarding warning signs for their teens and young adults. A recent study has shown that many teens felt pressured to keep their feelings to themselves. Therefore, as a parent as well as a provider, it is necessary to consistently check in with how they're doing and about different concerns that they may have. By doing so, you are really allowing them the space to be able to receive that support. For example, I have had clients, I have had clients come into group for depression and later reported that they felt unsure if they should share about additional concerns like substance use. An example of this would be a client initially coming in with depression and then being reluctant to talk about their alcohol use. But as they became more comfortable, we may be able to talk about ways in which they had used alcohol to fit in or ease their anxiety in different like social situations. Sometimes clients come in feeling as though they should focus on a specific thing that brought them in, like depression or getting back to school. So it is important to remember that oftentimes there really are layers to what people are coming to treatment for, and helping them peel some of those back and be able to inquire further. Okay, so risk and protective factors for substance use. Here we will focus on risk and protective factors. Although, I know we're looking at substance use here, but as I've said before, they really do go hand in hand with mental health risk and protective factors as well. So if we look over on the left at protective factors, some of these might include positive role models, having strong family cohesion, having little or no access to substances, positive peer support, known parental disapproval of substances, a strong connection to school, engaged in positive activities, the understanding of potential harm from use, and having the access to mental health and supportive services. Some risk factors on the right would be possibly having a history of mental health disorder, friends using around them, having a genetic predisposition, academic failure or a low commitment to school, bullying, family conflict, having a low perception of harm, normalization of use, or even parental approval for substance use. Many of these risk factors were also exacerbated due to COVID-19, and we've seen an overall increase in substance use since. I've noticed that of these risk factors, lack of structure, boredom, and little to no peer support are very common. I have heard clients say that those specific risk factors have influenced the start of their use. I have also heard clients report not knowing what to do and how to fill their time after trying to disengage or replace the negative coping skill, like quitting a substance or no longer engaging in self-harm. Creating structure and implementing new healthy activities can decrease risks. Activities some of my clients will often add to their schedule can include starting to attend 12-step meetings, exercise, getting a job, maybe going back to school, and participating in different hobbies. I have a client who loves playing piano. That's been really helpful for them. Reading, painting, drawing, like art can be really helpful. So all of these can be really healthy activities for them. Going along with protective factors, we have a student at Serenity who is, or I should say we do have students at Serenity who are involved in extracurriculars like sports or plays, and they will report increased motivation to get to school and do well so that they are able to play or perform, despite saying how much they generally did not like school. I have a client in particular that had a really hard time with school and was really unmotivated to attend. This client, their mental health declined due to family conflict regarding their poor grades and lack of attendance, as well as having really little to no social support or structure. This client missed a lot of days of school and had pretty low grades. They ended up joining a sports team specifically for this client. It was softball. Once she did this, she began making it to school every day, and due to the academic probation within the sports teams, client had to get all the grades up in order to play. So this girl in particular became really motivated, now attends school daily, completes her assignments, and has really reported improved mental health since implementing that structure and playing a sport after school. So this is an example of how much of a role protective factors really can play in someone's well-being. We've also been able to see a difference between kids who have a very supportive home life and parents involved in treatment versus those with higher conflict and disengagement from parents. So here are some screening tools that I have provided on the slides. So there are many formal screening tools that can assist in identifying substance use and mental health disorders. I've listed a few here that you can review to see if they would be beneficial to incorporate within your assessment. But in general, assessments and biopsychosocials should always include a section regarding substance use history and concerns. When working with teens and young adults, I've found it helpful to remind them of confidentiality and to let them know that their responses won't necessarily be shared with their parents. In my experience, I've noticed that teens and young adults have some resistance to being honest about substance use due to fear of getting in trouble, their parents finding out, maybe getting sent to a higher level of care, or more. We really work with clients on being able to share about their substance use and help them recognize that sharing about their use is considered progress and something not to necessarily get in trouble for. If at some point it does become a repeated use with little to no progress, then it may be appropriate to talk about or assess level of care. However, in my opinion, clients talking about their use is generally progress within itself. So it's important to note that. It can also be helpful to check back in about substance use after the initial assessment, once clients have become more comfortable and you've developed more of a rapport with that client. I found it most helpful to use a combination of informal and formal screening tools. Formal tools can be very useful to be able to document progress and outcomes throughout treatment. But I think it's really important to recognize what your own natural style is. And I'd suggest taking some time to look over some of these formal assessment or formal screening tools to see what would really work best for you in your practice. Okay, so what works for teens and young adults? Treating substance use disorders and mental health disorders concurrently requires a comprehensive and well-rounded treatment plan that incorporates a variety of services that address both disorders. Oftentimes, this can include CBT, motivational interviewing, contingency management, family involvement, 12-step or support groups or meetings, medication management, group therapy, and others listed have all been shown to have a positive impact on treatment outcomes. Two that really stand out to me would include group and family therapy. Working with teens and young adults, I've seen how effective group and family therapy can be. Studies show that people who engage in group therapy communicate more spontaneously and freely, build community connections, and have better treatment outcomes. It gives them the opportunity to provide and receive feedback, develop social skills, and have a sense of community and trust. Plus, sometimes receiving feedback from a peer can be way more effective than from a parent or a therapist. And I would say that our teens would be the first to tell us that. Oftentimes, young adults will come to us for treatment while struggling in college or maybe taking a leave from college. And things like collegiate recovery, sober dorms, and 12-step meetings while attending treatment can be very helpful. It is also important to work with them during treatment on aftercare planning so they are set up with the appropriate aftercare and resources like sober living, support groups, or ongoing treatment. I want to take a couple of minutes, though, to talk a little bit more about group because it really has been incredibly beneficial for the teens and young adults that I've worked with. So, I mean, at Serenity, we really like to meet the clients where they're at and try to allow some flexibility within our groups. We do incorporate psychoeducation on specific themes and topics and that we see that are emerging within the groups. But some days we also can tell that the group members really just want to be able to process things. So we will allow the group to work through whatever is coming up for them and at that time and really like give them the time to work through that. We also really like to create activities to keep this fun, educational, and therapeutic. Obviously, therapy is hard work, but I think it can also be a lot of fun and engaging for young people. A lot of times the kids will come to us and they will share how much they liked being able to connect with their peers and receive support from them. One of the most common things I hear is how relieved they were to hear that they really weren't alone and that there were other people their age that were experiencing something similar. Another common topic that comes up in group is family conflict and maybe how to improve relationships with family members. This also shows the importance of incorporating family therapy into treatment. Family dynamics can have a large impact on substance use and vice versa, especially when working with teens and young adults. High levels of relationship dysfunction and conflict and low family support may contribute to substance use, while substance use of a family member can also contribute to such family dysfunction. We can do great work with an individual, but it can be really difficult for long-lasting change to occur if we're not also working with the family that they're going home to every day. There are many different types of family involvement that programs offer that can be really helpful for teens and young adults as well. So family involvement can really be an incredible tool to clients. Family involvement, however, is really more than just family therapy. As you can see, there are many different different ways that family members can get involved while also utilizing their own support. Through family involvement, caregivers can learn to recognize behaviors consistent with substance use disorders as symptoms rather than simply a choice. For example, like lying, deception, denial, or relapse. Therapists can assist caregivers in identifying family interactions that may cue or trigger distress within the substance use disorder family member and learn to approach those interactions differently. Family members themselves may have developed their own maladaptive, symptomatic, often fear-based behavior in relationship to their substance use disorder loved one and could benefit from support for themselves. Oftentimes, a referral for a parent or family member to seek their own counseling may be very beneficial. And like an example of that would be, I have a client who was very resistant to treatment and abstinence altogether when they first came in. And we started doing some family work. And while working with the family, we learned that Dad also had struggled with addiction. And I think that was really hard for the client to say, like, well, I'm coming in, I'm working on myself, or I'm supposed to come in and stop using, but this is what's going on at home. And so as we started working on this and kind of addressing Dad's substance use, Dad was able to get his own resources. We were able to give him a referral, and for him to get his own treatment, the dad made the choice to attend 12-step meetings and therapy, and he himself actually got sober. And really shortly after that, client became really motivated for treatment upon seeing the dad's effort. And to this day, currently, both dad and client, the client that I was seeing, have multiple years of sobriety. And it can go to show how impactful family work can really be and how beneficial being able to provide those referrals for family members and just family members doing their own work can really be. At Serenity, we offer a parent support group and also family therapy, but we also encourage involvement within these additional support groups like Al-Anon, Nar-Anon, and NAMI mental health support groups. For those of you who may not be familiar with some of those support groups, Al-Anon, Nar-Anon, and Alateen are support groups for people who have loved ones struggling with addiction. Al-Anon is specifically for alcohol, Nar-Anon is specifically for substances, and Alateen and Narateen are the groups specifically for teens who have a loved one who is struggling with an addiction. You can find these local support groups online for your area. We will also have the links for these resources at the end of the presentation. So that will be one of the last slides you'll see. I've also noticed that clients whose parents and families engage in some form of family involvement often feel more supported, understood, and seem to have better treatment outcomes. So some of the benefits of family therapy are increasing family cohesion, improving overall family functioning, and adopting new solutions within the family. Early intervention and family involvement in adolescence can reduce the risk for the future. Within family therapy, family members can increase their understanding of the quote unquote problem and the impact that the family dynamic may have. Parents often learn healthier parenting practices and generally will report higher satisfaction as a parent after doing so. Generally, members in family therapy feel safe due to having that kind of mediator. Therapists can also address the elephants in the room or certain behavioral patterns that may have been the norm within the family. The intensity and type of family involvement varies among treatment providers and levels of care. So it's important to have an understanding of your client's needs. So obviously I was just referencing levels of care. I know I've brought it up a few times within the presentation. So levels of care generally refers to the intensity of services that are required to diagnose and treat a condition. Clients can move through different levels of care as their treatment needs change. A higher level of care that incorporates services in addition to individual therapy can be very helpful and at times necessary when working with clients with a dual diagnosis. I encourage all of you to familiarize yourself with the different types of levels of care, but as a general overview, I can go over them kind of briefly below. So IOP is going to be group therapy about 3 to 4 days a week, which can include psychoeducation, individual, group, family therapy, and more for a minimum of 6 hours a week for teens and 9 hours a week for adults. PHP is going to be a step up from IOP and provides similar services, but for about 20 or more hours per week. This is generally 5 days a week and can also have access to psychiatric care. Acute inpatient is generally going to be for crisis stabilization and has 24-hour care. This is a short-term stay and will generally help provide a recommendation for best level of care after the client has been stabilized. So basically, if your client is in crisis and at risk for harm to themselves or others, they will generally end up in an acute inpatient, whether that is done through you as the direct referral or maybe by going to the ER. Residential treatment will provide 24 hours care and typically will last about 28 days, but that's definitely depending on progress, the needs of the patient, and insurance coverage. Discussing levels of care can be overwhelming for families. So I think it's just really important to be able to break it down for them, as well as provide questions that they can ask. And I think it just can be really helpful in facilitating the best standard of care. Okay, so determining the levels of care. The American Society of Addiction Medicine's 6 dimensions can be used to determine the appropriate level of care for patients with substance use disorder, and can be incorporated into your assessment and considered when making treatment recommendations. It is also utilized by many insurance companies when authorizing services. Using ASAM could be an entirely different training though, so I'm going to do my best to give you a very general overview. And I've also linked some resources on this slide for you to view for after the presentation as well. So the first dimension is going to assess the client's risk for withdrawal. So generally, if there is a risk for withdrawal, a detox or residential level of care would be recommended. Dimension 2 explores medical conditions and complications and assesses if they need to be addressed and or how they may impact their treatment. Dimension 3 explores an individual's mental health history and current cognitive and mental health needs. So some questions you could ask are there current mental health issues that need to be addressed because they create risk or complicate treatment? Can they manage activities of daily living, which might include being able to like feed yourself, bathe, dress yourself, grooming, going to work, etc. And can they cope with the challenges? Dimension 4 is motivation or readiness to change. So what is their awareness of the need to change? What is their level of commitment and readiness for change? What is their degree of cooperation within treatment? And what is their awareness of the relationship to or of substance use to negative consequences? Dimension 5 explores individuals' unique needs that influence their risk for relapse or continued use. So are they in immediate danger of continued severe mental health distress or substance use? Are they able to recognize, understand, or identify skills to cope with challenges in order to prevent relapse or continued use or risk for suicide? And are they aware of relapse triggers and ways to cope with impulse to use or harm themselves or others? And then for dimension 6, we have recovery and living environment. So what is their recovery or living environment like? Do family members, significant others, living situations or more pose a threat to their safety, their engagement in treatment or recovery? Do they have financial, educational, or vocational supportive relationships? Are there any legal, vocational, or social service mandates for treatment? And do they have transportation, childcare, housing, or employment issues that need to be clarified and addressed? So again, just some of the questions that you can ask within each of the levels of, while determining levels of care within the dimensions. After assessing the risk for each dimension, you can better then identify the appropriate level of care. Okay, so I thought it might be helpful to just throw in a case study to help apply some of what we're talking about. So here is an example of a common case that I see within adolescents. We can take a minute to just kind of review this and identify what an appropriate level of care and treatment factors would be for Jennifer. So we have Jennifer, a 17-year-old female, she was referred by parents to treat depression and vaping marijuana. During the initial session, the client reported symptoms of depression which impacted her academics, extracurricular activities, family and social relationships, level of motivation, difficulty maintaining social relationships, some anxiety in social settings. She had difficulty concentrating and sleeping, and a history of self-harm and passive suicidal ideation. She also reported an increase in substance use over the past year. She has possible trauma and reported continued marijuana use about 2 to 3 times a week, and alcohol use 1 to 2 times a month. So, and she says that this is social and in order to cope with some of her anxieties. But this has impacted some consequences at home, recent suspension due to being caught vaping at school, an increase in family conflict, and recent change in friend group that also coincides with her increase in substance use. She reports being medication compliant, and she's already on antidepressants from her primary care physician, and is open to engaging in therapy with some resistance, mostly that she's concerned about having to stop using marijuana, but does report really just wanting to feel better. So I'll give us a minute to just think about that before I share. So based on the information here, it would appear that Jennifer could be diagnosed with cannabis use disorder, mild, and a mild major depressive disorder, single episode. So Jennifer has diminished interest and pleasure in most activities. She reports a depressed mood for extended periods of time, has difficulty concentrating, feelings of worthlessness, and self-harm. She also has an increase in the amount and frequency of marijuana use. And over the past year, she has continued to use despite consequences, and positive activities have been replaced or given up in order to use marijuana or engage in activities related to using. These things that I just described are what would qualify her for both diagnoses. And realistically, it seems like either diagnosis could be the primary, and I would highly recommend that she receive treatment for both the mental health and the substance use. So based on the information that we have, I would recommend that Jennifer participate in IOP treatment. She has no risk for physical withdrawal, no medical conditions, no recent self-harm, suicidal ideation. She has some willingness to participate in treatment, but is resistant to abstinence and has a limited awareness of triggers and coping skills, increased family conflict, and a lack of positive supports and activities while having difficulty maintaining relationships. I would want to make sure that the program offered consistent individual and family therapy in addition to groups, and addressed both the substance use and the mental health, as I've already said before. I think she would also benefit from psychoeducation regarding substance use, possibly going to 12-step meetings, and the link between marijuana use and teen depression. I think CBT and motivational interviewing could also be really helpful techniques. If Jennifer or her parents are resistant to IOP treatment, she obviously can start with outpatient treatment to help increase the motivation to then participate in IOP. If her use continues and symptoms do not improve, however, it would be important to continuously assess in order to ensure that she actually is receiving the appropriate care. Okay, so I know I mentioned this earlier, but here's a list of some some of the resources discussed throughout today's presentation, as well as some of the ones I will often provide my clients with. So you will receive, you should receive a copy of today's presentation, but you can also visit youthserenity.com/resources, and we will have the full list up there for you. Like I said, it can just be really helpful to have on hand to then give out as like a referral for some of your clients. I know that in my experience, clients have found that really helpful. So I guess that will wrap up the presentation, and we can move on to the Q&A. So I know some of you might have been asking questions throughout, so we can try to answer some of them now.
Yeah, thank you so much. That was so wonderful. I have been monitoring the questions here. There are a few. Did you feel comfortable with me reading them to you, or did you want to pull up the box?
That would be fine if you don't mind reading them.
Yeah. So the first question is, we have had questions about whether or not to diagnose substance use disorders when parents are not aware because of the more protected privacy guidelines around substance use information. Any thoughts of how to navigate privacy around substance use with family members and in diagnosing would be appreciated.
Yeah, that's a really good question. And obviously, Francesca, please feel free to jump in.
I was going to say, since I do a lot of the initial consultations with the parents, so if you want me to just jump in and.
Yeah, I mean, I was gonna say like some of the things that we often do as we kind of move forward within the treatment, but I think that would be helpful if you want to start it off.
Yeah, and I think for us, it might be a little bit different because we're kind of known as that dual diagnosis program. Parents end up calling and saying, hey, my kid's struggling with both mental health and substance use. But if you're, in more of a private practice or it comes up throughout treatment, I could see, all right, how do we navigate this? I mean, for us, because we work with the families, I definitely usually encourage, I call them all kids, but the kids to be able to share some of their struggles within family therapy or share it with their parents that, this is something that they're struggling with and that they want to work on. So we can kind of all collaborate together to help give them the best care possible. I think where it becomes really important to actually give that diagnosis is, to stop and think, if I don't give them this diagnosis, are they then going to be missing out on the treatment that they need? So, sometimes in order to, get them into the program, they need that primary substance use diagnosis, or it could impact insurance. So I think it would take, case by case basis, really looking at what does my client need right now? Do they need this substance use treatment? Do I need this diagnosis to get them that type of treatment? So yeah.
Yeah, I think that sums it up really well. And I would say too, it really is about working with the client and building that rapport to also be able to help them be able to share that information with their parents. And I feel like we generally have a pretty, I think clients can be very resistant, but at the same time, the good thing we have, I know we just talked about whether it's like a private practice versus like we have an IOP. So some of the clients will come in and start group, and like even group members will encourage that for them, which can be really helpful to hear from other peers. Like, yeah, I think it would be really helpful for you to kind of like be honest about what's going on. So I agree with the things that you just said as well, but I just wanted to throw that out there as well.
The next question is, do you see many eating disorders at Serenity? I assume that you do. And if so, do you treat them in-house or refer out to specialists? This is my specialty, and I know how complex treating all these issues at once can be.
So great question. Also great to know that that's your specialty. Very helpful. Yes, I would say we definitely do. I think that kind of like you had asked in the question, it really, you said you assume that we do. And I think, with all of the things that they're coming in for, I think it makes sense that they would kind of go hand in hand. It definitely depends on the client, but I mean, I know specifically we even have a client right now who is in treatment with us and was able to kind of start addressing the initial concerns about like the substance use and mental health, but is in the process of probably going to a higher level of care for specifically like for eating disorders. So we definitely will refer out. I think it's important to make sure that they're getting like specialized care. I don't know if you want to jump in on that, Francesca, but I definitely think like we try to monitor and like assess what's going to be what is the, I know we've talked about this, what is primary diagnosis, which can be hard at the time because I think that can be interchangeable. But I think if we find that eating disorder starts to rise, we definitely will refer out.
Yeah, you summed it up there. It's like, what are they at risk for the most right now? And does that, eating disorder need to be medically addressed as well? And just kind of keeping an eye on things. So.
Yeah, absolutely.
Yeah. Next question is, any suggestions on how to engage ambivalent clients that do feel like their substance use impact their functioning?
I think that just being able to explore that with the client is really helpful and helping. I know they're ambivalent, but it sounds like they do. If there is a part of them that feels like their substance use is impacting them on some given level, I would just explore that with them and be like, what is that like? Like where do you see that? Or where do you see this affecting you? And being able to kind of, I think in the beginning, it's about making sure that they know that it's, while, yeah, I would love to be able to help you come off of that substance, in the beginning, it's kind of also helping them see that, or I guess get that awareness that like, I'm not here just to say like, you have to stop. Like, I want you to also be able to talk through it and figure out like, why do you feel like this is the best decision for you? So I don't know. I think maybe throwing some of the pressure off the table and being able to say like, all right, like and kind of like, let's take this. So I think people worry that if they bring it up, then it means like, the therapist is immediately going to be like, oh, okay, you have to stop. And I guess I would say like, let them explore it for a little while. And I think it can really help with some of that ambivalence.
The next question, and this is to piggyback off what you just answered, but not only addressing resistance among teens, but resistance all around, even with the families.
Okay, so I think I would say resistance with teens. We do. I mean, I think it's very common to see resistance in teens. And at the same time, what I generally will do is like, we have such a wonderful group right now. And like what we really have, and I'm not just saying that, like it really, I think being able to kind of sit down with the client and just describe what that could be like and what, like, I like to kind of get on their level and just meet them where they're at and figure out like, help them see that this is a space for them. And a lot of the time they're coming in because maybe a parent thought that they should, or someone suggested it. And so sometimes I'll say to them, like, listen, like, I know this might not have been your first choice, but you get to be here and like, you get to make this whatever you want it to be. So, this gets to be your hour and like, no one has to know about what you're talking about. Like, this is for you. Like, and I think just like helping create that space for them where they're able to know that, like, I don't know, like, even if it wasn't their choice, like they have that autonomy when they're in the room and, they get to like talk about whatever it is going on. I also love to like build rapport in the beginning. So I'll sit and kind of like figure out what they like, like what are some shows you're watching? What do you like to do? Like, do you like playing sports? Find a connection, because that goes such a long way with teens. Like for teens, it's really about like being able to make them feel comfortable and feel like they can trust you. So I think that is so important. And when it comes to resistance with families, I think that can definitely be really challenging. I think that, like, as I said throughout the presentation, it's so helpful when there are family members that do want to engage. And so, I mean, one thing we try to do at Serenity is we do kind of say when they come in, like, hey, this is going to be a requirement. Like, we want you to at least like try to join a family group and we'll try to work with them. But like, we want you to be engaged. Like, we're going to want to call you and give you some updates. I think like trying to help them know right off the bat, like, this isn't just going to be for your kid. This is also like, we're going to need you to work with us on this. And I think sometimes setting that boundary from the start is helpful because then they know what to expect. But Francesca, anything else you would say on that?
No, I think you pretty much covered that. I think that some of the parents that maybe I've worked with is if you have another colleague or you're in a group practice, having, a director type person or somebody else kind of reach out to the parents and checking in with them. And maybe like for me, I often will just provide some psychoeducation, like, hey, like these are, some of the issues that we're seeing or some of the concerns that we have. And these are the reasons why we think it would be beneficial for you to participate. We'd like you to just come in and kind of check it out and then we can go from there. So.
Yeah, absolutely.
Yeah, one more question so far. Do colleges have access to clients' diagnosis for either mental health or substance use?
So unless you're, and correct me if I'm wrong, I don't want to speak out of context, but unless like they're specifically asking for accommodations or maybe like a medical withdrawal or something along those lines, generally a college does not need to know what your diagnoses are. But
yeah, I was going to say one of the things that we often get asked. So obviously we have to have a release to release any type of information, but oftentimes clients who come home will ask us to help complete the necessary forms for them to take a medical leave of absence or to re-engage in school. So anything that we're providing to the college, the client has then signed off on the release for and is aware of and is usually requesting us to send it in.
Yeah. So we'll make sure that they know exactly what that will look like so that there's no surprises.
But like, that's a common question we get from parents too. It's like, okay, well, you're going to give my kid this substance use diagnosis. Who's going to know about it? And just being able to educate them and let them know, like, no, this is protected information and nobody's going to know about these diagnoses unless, you are releasing that information. You're authorizing that, release of information. So.
Mm-hmm.
Well, we've come to the hour. Thank you, everybody, for the questions. And thank you, Kaitlyn and Francesca, for jumping on and sharing the information. If anybody has any questions regarding the CE or anything regarding admission for Michael or Inovo Detox and Maryland Addiction Recovery Center or Serenity, please don't hesitate to reach out to us directly and have a good rest of your day. Thanks for joining us.
Thank you, guys.
Thank you.
Thank you.